Good afternoon. My name is Indranil Chakravorty. I'm a Director of Medical Education at St. George's University, and I'm also the chair of the Bapio Institute for Health Research, and work with the Faculty of Life and Medical Sciences at University of Hertfordshire. I've been leading the project called Bridging the Gap, which is basically a tackling differential attainment initiative, which is undertaken as part of the Alliance for Equality in Healthcare Professions. And today I'll be talking to you about this particular project and why this is important to you. Let's start first by talking about differential attainment. So essentially, it's defined as an attainment gap which exists for certain groups of individuals, not because of their ability or their motivation or their academic prowess, but mainly because of systemic deficiencies or systemic bias that exists, which makes it unfair for them. And these inequalities can be really deep-rooted and go back in time. I'm sure many of you would have seen this amazing cartoon which describes why equality and universal access is not a good strategy, because individuals are different and bring with them a lot of different legacy issues and experiences, which has to be taken into account if one were to give equal opportunity for all. And this slide really shows it very well. And why is equality important? Because it is fundamentally a human right, guaranteed and accepted by almost all countries across the world. In the UK, the Equality Act of 2010 guarantees equality for all, and therefore it is not only a moral and an ethical imperative for us, it is also a legal imperative to guarantee equality. Looking briefly at the history of differential attainment, if you look into historical records, you will see that it dates back even before the inception of the National Health Service in 1948 within the UK. It started initially with the differential access, treatment, and opportunities that were given to immigrant health professionals, a lot of whom came from Europe to the UK following the war. Over the years, it has affected people in various different ways, including Irish travelers, Jews moving from Europe, South Asians, Caribbeans, African, Chinese, East Europeans, Filipinos. The list is endless. It also extends to people who've been born and brought up in the United Kingdom, and the bias exists from gender perspective, disability, sexual orientation, and many other protected characteristics. And it also extends to social and economic deprivation. All of these are very intricately linked. Differential attainment is not unique to the United Kingdom, and it's present in almost all countries across the world. In the UK, the 2014 is a watershed year, and in that is the first year that the British Association for Physicians of Indian Origin took a court action against the Royal College of General Practitioners because of a perceived and documented differential attainment in the clinical exam that was required for getting membership of the RCGP, which, as you know, is one of the essential steps to progress to become a GP. Bapio's case was based on the fact that the performance of international medical graduates and UK graduates from a Black and Asian minority perspective was about 3-4 times less than any UK white peers, and therefore they alleged that the the exam was discriminating on the basis of ethnicity and race. The legal case was lost because the judge decided that there was no overt discrimination in the way the assessment was done. However, there was a requirement placed on the RCGP to tackle the phenomenon of differential attainment. Otherwise, the expectation was that this would come back to court again. The GMC, taking on from this court judgment, undertook a major undertaking of collaborative focus groups back in 2015, and they found that the research up to that stage mainly looked at high stakes exams like the RCGP exams, and broadly found really no evidence of conscious bias in the nature and structure of the examinations. However, the performance differential continued to be recognized as a problem. Differential attainment is recognized in almost all aspects of the medical profession and not just restricted to the medical profession. And we can see that medical school entry it discriminates against people from deprived backgrounds, state schools, Black students. Postgraduate selection is less researched, and we actually don't have much good figures. But I anticipate that the same would be true. At consultant entry, the RCP have done significant surveys which shows that there is a gender and a Black and Asian minority discrimination that exists unconsciously within consultant appointments. In GPs, we know that there is disability and driving are factors which lead to discrimination. And also we know that there is a huge scope for widening perspectives. So what are the causes of differential attainment? And we know that there are multitude of causes. Primarily, it is a manifestation of systemic bias. And this systemic bias can be conscious, unconscious, but exists on a variety of factors. And we know that they are all significantly interlinked. So race and ethnicity and gender leads to social and economic deprivation and vice versa. There's also a significant group of international medical graduates, and UK has about 30 to 40% of its workforce from international professionals, and they are a particular group that suffer the phenomenon of differential attainment. There are also, at a smaller level, at individual level, certain factors such as learning styles, cultural background, first language, second language ability, and also significant input from lack of adequate supervision. There is evidence that support is considered to be beneficial, but the research evidence on how good support mechanisms are or schemes are is still to be researched, and it's one of the areas that we are particularly looking into. And there is also significant debate, as you'll be aware, from the recent government racial disparities report, that ethnicity or a group such as Black and Asian minorities, which is a significantly disparate group, is also not the best way to study something like this, as is primary medical qualification from overseas, because we know that medical education is very different in various countries. And what is the impact of differential attainment, and why should we be bothered about it? Because we know that at a micro level, at an individual level, like people like you and me, it affects career progression. It affects the way you can take up leadership roles. It affects your application for specialty posts, for consultant posts. It affects the way that you could take up research and academic posts. And it also has a significant negative impact on well-being and causes psychological distress. At a medium organization level, we know that it leads to demotivated workforce, demoralization, and where training has to be extended in because of failure in exams and other such areas, we know that the cost of training really goes up. And at a major level, we know that this impacts on patient safety, progression, and workforce distribution. And there are significant disadvantages in certain parts of the country where there are significant gaps in workforce. So the Bridging the Gap project was started back in August of last year under the Bapio Institute for Health Research. And you can see the number of partners that we are working closely with. And we also have a whole panel of experts and grassroots organizations that have worked together to try and find solutions. This particular project is looking at the entire spectrum of differential attainment, from recruitment to professionalism and fitness to practice. So there are 6 particular strands. The process is simply that we have groups who have worked on a thematic synthesis of all the literature that exists at present, then produce papers. And you will, if you go to our journal, you will see the list of our papers that give you a summary, an overview of the current research evidence. Then we have priority setting partnerships where groups of researchers, grassroots professionals, and experts have sought through the research and found out the key themes. We've then taken the key themes to workshops where, again, around 30 or 40 people from different walks of the profession have come together, discussed options, and clearly looked at solutions. The product, which I'm writing at present, will be our Bridging the Gap report, which will be presented later on this year. And what we're expecting to give is a set of recommendations with some early actions, which can be implemented straight away where the evidence is strong. We're also looking at some policy changes that would help to change the system and make it fairer, and then identify areas of further research. So the workshops have now all concluded. The most recent one was on recruitment on the 31st of March, and we are now working through the report. We're also looking particularly at intersectionality, so looking at not just individual factors such as ethnicity or gender, but seeing how each of these factors multiply for people to produce a much bigger attainment gap than you would expect from this. And this is an example where the work we did in research, an academic workshop, found that of the published research, only very few papers looked at the intersectionality, and that is one of the biggest areas that we will be working. So what do we know from our work so far? We know in the assessment section that if one were to change from high stakes assessments, which is one exam at the end of 3 years or end of 5 years, to multiple low stakes assessments, or a combination, a hybrid mechanism where proportion of the marks come from low stakes real time assessment combined with high stakes assessment, that will lead to a much fairer system. We know that formative feedback is very poorly given to individuals who then tend to fail at the end. We know that support should be individualized, and universal systems don't work. We know that there are significant elements of within exams, for instance, communication versus procedures versus clinical skills give very dichotomous results. And again, there are ways to improve that. We know that exam results affect ARCP progression, and perhaps the guidance is that we should not be putting all our assessments into making that particular judgment and taking a much more holistic view. We also know from the research and academic workshops that there is very poor data on recruitment into research and academic roles. We know that there's hardly any data on longitudinal progression within the research and academic careers. We also know that many of these committees don't have a equality assessment or committees which are representative of the people that they serve, that there are standards and commitment which are required. We know there are significant lack of role models from, for instance, Black and ethnic minority academics. And we also know that mentorship is also not universally available. From leadership roles, so this is about people taking on leadership roles within their jobs as consultants or primary care physicians. We know there are, again, very few senior leaders who are from a BAME background, very few senior leaders who are from female gender. For instance, we know that the data on workforce race equality standards for the last 5 years have shown very little progression, and there are organizations which are doing well, and there are ones which are really languishing at the bottom of the equality, diversity, inclusion perspectives. We know that benchmarking, perhaps in the type of work that Athena Swan has done with gender, would probably help. We know that mentorship and sponsorship are very important factors, and similarly, in recruitment, we know that widening participation works. We know that flexible training should be encouraged. We know that sponsorship is important. We know that disability and dyslexia screening should be available for all, and appropriate mitigation provided. We know definitely that EDI representation in all committees would certainly help. From a career progression factors, again, accountability of organizations. So holding an organization accountable for the progression of all their staff and faculty development are really important areas. Within professionalism, how complaints are dealt with, or fitness to practice, we know that there is significant disparity in how people are dealt with. And again, data benchmarking, making organizational chiefs accountable for the differential attainment and tackling it would make a significant dent in this. And overall, for the individuals, mental health, psychological health, self-worth, all of these measures will improve well-being, will improve recruitment and retention into the profession, which is a significant challenge for us. This is an excellent slide which looks at how tackling inequality versus equality, where you provide differential support to people to try and access things might improve. We also know that when we go from equal access for all to individualized support, as you see in equity angle, that also improves things. But ultimately, in order to improve the society, one has to look at all these factors and make sure that we are looking at outcomes. So from a trainee perspective, at present, as you go on to either senior roles, getting your consultant roles, or moving on to more research, academic roles, senior leadership roles, you will face these sorts of unconscious biases that exist in society. And the more you are aware of it, the more you ask for help right at the beginning, the more you look at the data that shows the disparity, the better prepared you will be. And when you are in senior roles, you will need to take this into account and support your trainees in such a way that they are able to get the support they need in order to excel and reach their potential. I'll stop at this point, and if I'm able to join you here, I would be happy to take some questions, and I'm also happy for you to email me any questions through the organizing group. Thank you very much.